Hello, and welcome to By the Book, a podcast series from ASCO that features engaging conversations between editors and authors of the ASCO educational book. I'm your host, Dr. Hope Rugo. I'm the director of the Women's Cancers Program and Division Chief of Breast Medical Oncology at the City of Hope Cancer Center. Today, I'm delighted to be joined by Dr. Peter Lee, a radiation oncologist and instructor at Mass General Brigham Cancer Institute in Boston, with a special interest in exercise oncology. He's the lead author of a fantastic paper in the ASCO educational book this year titled Beyond Chronological Age, Frailty, Geriatric Assessment, and Personalized Care for Older Adults with Genitourinary Cancer. We'll discuss frailty and its association with clinical outcomes and practical strategies to implement screening. We'll also address oncology-focused geriatric assessments, interventions to optimize vulnerabilities, and emerging innovations such as digital health tools and AI in geriatric oncology. As our population continues to age and live longer, this is an increasingly important area for focus for all oncologists. Our full disclosures are available in the transcript of this episode. Dr. Lee, it's great to have you on this podcast today. Thanks for being here.
Thank you, Dr. Rugo. It's great to be here today.
So let's get into our discussion. Congratulations on your fantastic paper, Dr. Lee, which notes that by 2030, 70% of all new cancer diagnoses will be in older adults. This reflects a growing need for oncologic care paradigms that address the unique needs of our aging population. In addition, this is especially relevant in genitourinary cancers, as the current median age at diagnosis for prostate, bladder, and kidney cancers are 68, 73, and 65, respectively. These are generally older age cancers. Chronological age is a useful initial indicator, but assessments of physiologic age, such as frailty status, are key factors that determine safety, quality of life, and independence following cancer therapy. Indeed, chronological age has become in some ways less important as an indicator. Tell us how frailty is defined, what is frailty, and what is the difference between chronological age and physiologic age?
Yeah, that's a very good question, an important one, and I think one that's actually a little bit more difficult to define than we might initially think. Speaking to frailty, there's not one agreed upon single definition, but we do use the term frailty as an attempt to try to capture or represent a collection of physical, mental, and social vulnerabilities that one might experience that may also be associated with one's decreased ability to tolerate certain stressors or to recover from stressors in one or more of those domains. So first, now I know that's a little bit nebulous, but I can talk a little bit more about at least two models that we use medically to try to better define and assess for frailty, right? And so the first one is what we call phenotypic or physical frailty. And this is what you might think about when you just generally think about frail, what you might picture in your mind, right? And so this physical frailty model, it assesses 5 physical domains: unintentional weight loss, exhaustion, low activity, slow gait speed, and weak grip strength. And scoring patients in these categories allows us to try to categorize them into frail, pre-frail, or robust categories. So physical frailty, that's one model that we can use. Another definition that we can use is what we call the accumulation deficit index. And so this is an index that tries to assess a broader spectrum of categories, moving beyond just physical limitations. And so what this index is, it's essentially a survey, and you can survey a patient in up to 40 assessments. And these may include things like medical diagnoses, patient-reported distress or fatigue, polypharmacy, and of course, physical limitations. And these assessments, essentially, they're scored on a binary scale of 0 to 1. And the score that you get is essentially in how many of these categories do patients score positively for versus how many of these assessments you've asked the patient. And then you come up with this ratio. And the greater that ratio, again, indicates a greater level of frailty. So to summarize, there's not one agreed upon definition, but at least how we approach this in our clinic is oftentimes we can think about it either in physical frailty or this accumulation deficit index type of frailty.
These are really important because I know that This is a way of trying to get around the idea of chronological age being a determinant, since we certainly see very healthy older people who can tolerate more treatment, have a longer life expectancy. And then we see younger patients who are quite frail and aren't going to manage treatment or have a short life expectancy. And I guess the idea of frailty really is a way of trying to understand the tolerance of treatment overall and survivability potentially. But, we have busy oncology clinics, and it can be incredibly difficult to try and understand how to screen patients. What are the validated frailty screening and geriatric assessment tools that we can implement in our busy clinics easily? How do we access this? How can you talked about a multi-scoring system? That sounds overwhelming for a busy oncologic clinic.
Yeah, definitely. And this is something that we really talk about in the paper, and that there are a number of tools that we can use as the screening tool, where I think the main take home message here first is that, as you alluded to, a full comprehensive geriatric assessment is sophisticated and highly resource intensive, right? And certainly not something we expect every single provider to be doing for every single patient. But what we hope is that with this list of different various screening tools, which are simplified and streamlined, it might allow more providers to first identify patients that are then good candidates for referrals to a more comprehensive geriatric assessment. And so, again, as I mentioned, there are a large number of frailty screening tools. And I think the main point here is that there's not one best screening tool, but what we think of is the best screening tool is the one that you feel most comfortable using in your clinic and in your workflow. And so there are certain things we can do. Physical assessment. So an in-office test for something like gait speed or grip strength. And actually hand grip strength, that's something I've implemented into my clinic workflow. But there are other tools that maybe other providers are more comfortable with. Patient-filled surveys that you can implement into, say, a pre-visit workflow or pre-visit booklet that you give to patients. There are scores that are derived from lab values or the electronic medical record that can help you highlight at-risk patients. And so again, I think in our paper, we list 17 different screening tools, but again, really the best one is the one that fits into your clinic workflow, right? And for me, it's hand grip strength that I use, but I know other providers, they found very good ways of implementing surveys that they'll give to patients as part of their pre-visit checklist. So again, I think some type of screening is better than no screening.
So, what people would do would be to implement this in the clinic and have patients over a certain age, say 60, have their team send them as part of, when we ask for past medical history or update on medications, you would send it out at that time so that when you saw the patient, you would already have that information at hand.
Exactly. Yep.
And then grip strength is an interesting area as someone with some cervical neuropathy. I wouldn't want to be called frail because I had poor grip strength. So you have to take comorbidities. You have to take some functional status into account and have alternatives if people, for example, aren't able to have big grip strength for whatever reason. I think you always have to have an alternative, right?
Exactly. And I think that gets back at sort of how complex frailty or defining frailty can be. It's often beyond one single domain or one single metric. And so thinking about how to address all of that, but both succinctly into our busy clinics, it can be challenging.
Yeah, I think that having some kind of a pre-screening tool for patients in oncology and in the particular areas here, genitourinary cancers that you've highlighted, seems to be very important. But I guess one of the things that we struggle with some, and I focus in breast cancer, is how we're going to adjust our treatment considerations, obviously as part of a shared decision-making process for frail and older patients. And this is an area that you focus on in patients with prostate, bladder, and kidney cancer. And this is probably the key for the oncologist in clinic and radiation oncologist surgeons to try and understand. Now you have your idea about how frail the patient is, what their limitations are. How do you implement this in treatment? I'd encourage my GU colleagues to really dive into the section of the manuscript that talks about specific treatment considerations. And I would love it if you would comment on this section and what we do, how to take this information into practice.
Yeah, absolutely. And so we chose, again, to highlight the three most common GU cancers that we see, right? Prostate, bladder, and kidney. And perhaps more important, these are the three diagnoses that often present in the older populations, as you mentioned earlier, right? The median age of diagnoses in the high 60s to early 70s. I think in the overarching theme of this section is we talk about that we have a already have a large variety of treatment options that are increasingly expanding, right, with our developments, and that the treatment algorithms for these different diagnoses are becoming increasingly complex. And when we see patients in clinic, they often have initially a variety of treatment options, such as surgery, organ preservation, or different types of systemic therapies or neoadjuvant treatments, all of which may have excellent oncologic outcomes, but they come with a very unique set of side effects and unique set of burden. What we discuss is really highlighting the importance of, again, appropriately selecting and again, often using frailty as a tool to help us select the appropriate type of treatment for the appropriate patient. And I think really moving away from, say, historical cutoffs of saying, oh, just based on age, this patient is not a surgical candidate, or based on one particular comorbidity, they shouldn't get this type of medication. I think really moving beyond those historical evaluations, but really taking the frailty model and integrating that into our treatment decision. And then also involving the patient. And this is something we highlight, I think is very important. And I think, we talk about the shared decision-making process where there's a number of treatments, they have great oncologic outcomes, but really talking to the patient and understanding what fits best in their lifestyle and their life goals.
That's so incredibly important. I mean, you think about somebody who, might want to do everything, but has a life expectancy of 2 or 3 years, and you're going to be spending 6 to 8 months of it and potentially longer for a recovery period doing treatment. You really have to balance these aspects and discuss this with the patient in the most open way possible. And their families, I think, in many cases for our older patients are also involved. So it's very complex. And I think adding in this assessment of frailty is very, very important in the discussion with patients and interpretation of what treatments are appropriate.
Absolutely. And I think one thing to add actually in this that I want to highlight, one of the challenges, and we talk about this in the paper, is that the clinical trials that we base a lot of our treatment decisions on, they overwhelmingly represent a younger patient population. That's really important to remember, and that's something that we should be thinking about as we continue to design these practice-changing trials, is really thinking about how are we enrolling patients and how can we accurately represent, right, the older population and the frail population that we often encounter in our clinics.
We always take the older patients and do sub-analyses, but we're looking at the best of the best. These are patients who have perfect organ function and functionality, even without frailty scores. So it's a really important. But we can optimize our care for older adults. And there are a number of multidisciplinary interventions that you also discuss. Exercise oncology, where you've really been focusing some of your efforts in your clinic and research, nutrition, pharmacy, telehealth, palliative care. Tell us a little bit about these areas and how the general oncologist who's seeing these patients, or GU oncologist, any oncologist for that matter, can implement these.
This is bringing in, right, the multidisciplinary care team model into cancer care. And it's one of the goals of frailty screening is, again, I don't think it's reasonable to expect a single provider to be an expert in all of these domains. Some of us have our specializations, whether it's exercise or maybe nutrition, technology. But I think really using, again, frailty screening to identify patients that should then be referred to specialists and experts in these areas. And there's good data on it, where patients who are referred earlier to, say, a physical therapist or to a nutritionist, it helps them get through treatment better. And it provides improvements in quality of life, and it provides sometimes even improvements in outcomes. I think extrapolating from a different disease sites. So from lung cancer, right, there's this really practice-changing trial that looked at early palliative care referral for appropriate patients with advanced lung cancer. And that simply an early palliative care referral, that's all it took, not only resulted in improvements in quality of life, but even in survival, the gold standard of our trials. And so again, I think working closely with our specialists and knowing and trying to identify when's the right time to bring in a specialist for a particular patient is very important.
Yeah, I think that's a very important point. And I will say sometimes people look at these lists of where to refer patients and they don't know how to get them there. But I think all larger institutions have palliative care and supportive care groups that can see patients so they can be referred from the outside as well. And then, I know that we do try and have updates. For example, having every other visit be telehealth, if that's feasible, may help patients as well. Medications, we have nutritionists in cancer centers that can help as well. So again, these referrals from outside are also possible for our colleagues who are in smaller practices that may not have all these specialties. And then exercise oncology, is a growing area of great importance. And I think that there will be a lot more tools for cancer patients in terms of optimizing exercise for their individual situations. And I know you're working on that. And as we get into our last question here, talking about the exciting emerging innovations leveraging digital health tools, these, I think, have helped us to provide some of these resources. And I'd love to hear about that. There's also the great interest in designing trials that better represent older adults and really applying implementation science to bring these trial-based interventions into routine clinical practice. Tell us a little bit about your interest in those innovations, the timelines. What most excites you?
Yeah, I think definitely a lot of exciting things going on in this area. And essentially, to summarize, I think we live in an age of data, right? Immense amounts of data. And these days, of course, AI has become a buzzword that's in everything to the point that AI probably doesn't mean anything anymore. What do we mean when we say AI? Is I think of how do we process the data that we have access to and how do we best leverage the data that we have? And I think one thing that I'm very excited about and talked about this in the exercise space is wearables and teletracking. I work in Boston. Having someone come to Boston 3 days a week to do exercise is oftentimes not feasible. We have the ability now to prescribe exercise regimens and to follow patients real time and see how are they doing. We can track their heart rates. We can track their respiratory rate. We can look at what intensity and what intervals they're training at. And it allows us to really monitor patients almost 24/7 if we needed to. In some of these trackers, you can assess for weight loss and you can assess for caloric intake. You can assess for sleep. So I think this era of technology and being able to monitor patients, what that's going to allow us to do is change our follow-up from a static model to a dynamic model. You mentioned this earlier. Sometimes we'll see a patient for follow-up. We say, hey, let's see you every 3 months for a year and then every 6 months thereafter. But if we can track patients real time, we can turn that into a dynamic follow-up model where we can see, oh, this patient for the last 3 weeks has lost weight, has lost activity, has disturbed sleep. Let's bring them in sooner. Let's have an earlier intervention versus someone else who's doing great. Maybe, hey, you don't have to come into the city. Let's do it via telehealth. Again, it's leveraging technology to collect data and then learning how to use that data and then allowing that to be more dynamic with our care.
Yeah, that's really important as we move forward. I think in this electronic age, I agree with you that AI is going to have a really important role, but we need to be very careful about how we take data and put it into clinical practice right now until we really understand the concordance. This of course comes up in pathology all the time now and to some degree radiology, but you can use digital health tools now. This is how you assess frailty, right? And try and understand decision tools, but also potentially, I hope at least, that there will be exercise tools that are more accessible to our older adults.
Absolutely.
Is there anything that you would recommend now that you find particularly useful for our listeners that they would direct patients towards, or would you just do a Google search?
It's a very complicated area, and I think there are some controversial topics here. One, I would say there are a lot of community resources that, I think we should be taking advantage of. The YMCA, right? The Live Strong program is fantastic. What can patients do on their own? One, the idea is something's better than nothing is often true, but I think also being intentional about what we do, right? Not doing activity just to do activity, but trying to think about what kind of activity are you doing and what's the goal of that activity? Is it strengthening muscles? Is it increasing cardiovascular health? Is it increasing flexibility or mobility, right? And again, being intentional about the activity that you're trying to do and what you're trying to achieve as far as a output or a physiologic response.
That's incredibly helpful. It's been fabulous to talk with you. We could keep talking forever, but we want to share this information with our colleagues. And I would really encourage everyone to read this great contribution to the ASCO educational book, looking at chronological age and evaluating frailty, geriatric assessments, and personalized care for older adults with genitourinary cancers, because it gives you tremendous tools, regardless of whether you focus in GU cancer or not. And I think that we're going to see a lot of expansions in these areas as we move forward with your contributions. Thank you so much, Dr. Lee, for sharing your fantastic insights with us on the podcast today.
Thank you, Dr. Rugo. Really appreciate your time. This was great.
And thanks to our listeners for joining us today. You'll find a link to Dr. Lee's EdBook article in the transcript of this episode. Please join us again next month on By the Book for more insightful views on the key issues and innovations that are shaping modern oncology.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.